If you're in business, you probably have a website, but can your site handle your growth? How many visitors before your site slows down or crashes? What about storage and data security? From web hosting to virtual servers, Pair Networks provides the online infrastructure you need to start, grow, and flourish. When it comes to security and updates, don't worry, we've got you covered. Our 24/7 US-based customer support is the best in the industry. No frustrating chatbots or sitting on hold for hours. Check out pair.com today to learn more. That's PAIR.com.
Welcome to the Attention Deficit Disorder Expert Podcast Series by Attitude Magazine.
Hello, I'm Carol Fleck, and on behalf of the Attitude team, I'm pleased to welcome you to today's ADHD Experts presentation titled Current Guidelines for Treatment and Behavioral Interventions for Tourette and Tic Disorders. Tic disorders look different on everyone. Some are vocal, some involve head movements, others look like rapid twitches. Tic disorders are most often seen in children. They co-occur with conditions like ADHD, OCD, anxiety, and mood disorders. Treatment isn't always necessary. Doctors may suggest a wait-and-see approach for milder symptoms. For children with tics that affect daily living, treatment can help decrease the severity and frequency of symptoms. In today's webinar, we'll learn about the different types of tic disorders, including Tourette's disorder. We'll discuss co-occurring conditions and associated impairments, as well as available treatment options and how well they work. We'll also learn about smart parenting strategies, including what parents shouldn't do. Leading today's presentation is Dr. John Piacentini. Dr. Piacentini is a board-certified clinical child and adolescent psychologist and professor in the UCLA Department of Psychiatry and Biobehavioral Sciences. He directs the UCLA Child OCD, Anxiety, and Tic Disorders Clinic and Tourette Association Center of Excellence, which provide diagnostic evaluation and treatment for children and teens with these conditions. He also directs the UCLA Center for Child Anxiety, Resilience, Education, and Support, which provides education and programming to parents, teachers, and clinicians about anxiety prevention and management. Dr. Piacentini's research focuses on the development and testing of effective treatments for youth OCD, anxiety, tics, and body-focused repetitive disorders. Before I hand over the microphone to Dr. Piacentini, I have just a few housekeeping items. Those of you tuned in to the live webinar may submit questions for the expert at any time by navigating to the text box under the video player. To download the slides, click on the Event Resources section of your webinar screen. And if you're interested in the Certificate of Attendance option, look for instructions in the email you'll receive about an hour after the live broadcast. If you're listening in replay or podcast mode, visit attitudemag.com and search Podcast 422 to access the slides, the webinar replay, and the Certificate of Attendance option. If you support the work we're doing here at Attitude to strengthen the ADHD community, we encourage you to visit attitudemag.com/subscribe and sign up for Attitude Magazine. You won't want to miss our special Success at School issue in the latest fall issue. Learn how to set smarter IEP goals, how to help your child build resilience, how to win over a new teacher, and so much more. Subscribe today for your family or to share with a teacher or a loved one who could benefit from greater ADHD understanding. Finally, the sponsor of this webinar is Inflow. Inflow is the #1 app to help you manage your ADHD. Developed by leading clinicians, Inflow is a science-based self-help program based on the principles of cognitive behavioral therapy. Click the link on screen to download now on the App Store and Google Play Store. Attitude thanks our sponsors for supporting our webinars. Sponsorship has no influence on speaker selection or webinar content. So without further ado, I'm so pleased to welcome Dr. John Piacentini. Thank you so much for joining us today and for leading this discussion.
Well, thank you very much. It's a pleasure to be here and talk to your to this audience today about Tourette's and tic disorders. Now, some of you may have heard of Tourette's disorder. Some of you may have heard of Tourette's syndrome. It also goes by Tourette disorder and Tourette's disorder. There's a lot of different ways to label this, and it's all the same thing. Historically, it's been called Tourette's syndrome. But a few years ago, the American Psychiatric Association published their latest version of the Diagnostic and Statistical Manual for Mental Health Disorders. And this is the list of all of the criteria and really defines how to make a diagnosis of a specific problem like ADHD or anxiety or depression. And they settled on the term Tourette's disorder. And so I will be referring to this today as Tourette's disorder, but it's the same as syndrome. You may hear people talking about TS or TD. Again, it's all the same. So what we're going to talk about today are what are tics, what is Tourette's disorder, what problems are associated with tics, what are the best treatments for tics, how well do they work, and finally, there's been a lot of interest lately in a big increase in the number of patients that are presenting with something called functional tics. And I'm going to save a little bit of time at the end to talk about that as well. Now, this talk is really focused on children and adolescents, but a lot of what I'm saying also pertains to adults with tics. And the treatments are actually quite similar for children and adults. And I guess that's probably the take-home message if you're interested in learning more about adults. So what are tics? Well, tics are, quote, sudden, rapid, recurrent, non-rhythmic, stereotyped motor movements or vocalizations. So what does this mean? Tics are rapid. Tics really kind of come on. And if you've seen somebody with a tic, you'll notice it tends to be a rapid movement that comes on all of a sudden. It's non-rhythmic. It's not like necessarily tapping your fingers for a period of time or tapping your foot. Something like that. It really are kind of rapid movements. They can be jerky, oftentimes is what you see. That would be non-rhythmic. And tics tend to follow specific kinds of patterns. So people might have a hand waving tic, an eye blinking tic, a head shaking tic. And these, when they do these, they typically do them the same over time. And then vocal tics also are tics where you make kind of sudden, rapid noises. It's not a gradual, slow recitation of a poem or something. It's usually shouting out words or saying words or syllables or grunts or snorts, again, that occur pretty rapidly. Tics most frequently involve the head and upper body. They occur many times a day, nearly every day. And they often change anatomic location and frequency and type over time. And we're going to talk about this a little bit in a minute because it's important for diagnosis is the pattern of which tics occur first and where they occur. And again, we have motor tics and vocal or phonic tics. So what are motor tics? Well, when we think about motor tics, we think about simple tics and complex tics. Simple tics are really sudden, brief, meaningless movements, little bits of movement like an eye blink or jerking your eye to the side or rolling your eye, a grimace, a twitch, a mouth movement, something like this, very quick, head jerks, social shrugs, rapid jerks and twitches. Complex motor tics are slower, longer. They may look more purposeful, like it's a regular behavior. The simple tics don't look like something you would want to be doing on purpose, but a complex motor tic can be touching objects, arm thrusts, thrusting your arm out, making hand gestures, bending or gyrating, dystonic postures, which would be like moving and tensing parts of your body, and then copropraxia, which would be obscene gestures, which are pretty rare, but they still occur. With vocal tics, we think about the same demarcation between simple vocal tics, sudden, meaningless sounds or noises, throat clearing, coughing, sniffing, spitting, animal noises, grunting, hissing, sucking, other simple sounds that really are meaningless. Again, there's probably no reason somebody would doing these, although again, coughing and throat clearing and sniffing are normal behaviors as well. But they're pretty rapid. They happen a lot, and they are loud enough where you would hear them. Complex vocal tics are more meaningful utterances. They're still pretty sudden. They kind of come on rapidly. And it might be syllables, words or even phrases, probably not long sentences, although we have seen that occasionally, but somebody shouting out, shut up, stop that. Coprolalia, if everybody that ever knows anything about Tourette's knows that coprolalia is what is always seen as the representative symptom. If you're watching a movie and somebody has Tourette's, if you're watching a TV show and somebody has Tourette's, they're always cursing. And coprolalia is the use of obscene or aggressive words. And we'll talk a little bit more about that as well. Now, coprolalia is actually not that common. Only about 10% of individuals with tics have coprolalia. So even though you see it all the time, and when we tell parents, we give them the diagnosis of tics, oftentimes the first thing that comes to mind is my child going to be cussing or swearing or using obscene words. And again, it's relatively rare. Palilalia, where it might be a tic where the child would echo themselves when they're talking. They'd say, hey, goodbye. We see this also in autism. And echolalia, where they would echo others. So if you tell something to a child, they may echo that. Again, we see this in other disorders. It also can occur in tics. And if you hear somebody echoing the self or others, again, it could be tics. That doesn't mean necessarily that the child has a neurodevelopmental disorder. So again, the DSM-5 tic disorders, there are 4 of them, actually 5 of them. Provisional tic disorders are tics that are present less than 1 year. And this is important because, as I'm going to show in a little bit, tics are very common in young children. But in most cases, almost all cases, the tics that young children express disappear after a few weeks or even a few months. So we wouldn't give them a persistent or chronic tic disorder, but we do want to note that these kids are experiencing tics at some point. So when a child first comes in for diagnosis, if the tics have been present for less than 1 year, we give them a provisional tic disorder. If the tics last longer than a year, then we would give them a persistent motor or vocal tic disorder. And this just means that the tics are longer standing. And as it sounds, a persistent motor tic disorder is a child that has motor tics only, no vocal tics, occurring longer than 1 year. A child with persistent vocal tic disorder would be vocal tics only, no motor tics. They only make sounds, occurring longer than 1 year. Vocal tics only, persistent vocal tic disorder is actually quite rare. We don't often see patients coming in, children or adults, that only have vocal tics. And again, I'm going to explain this a little bit more in a minute. So what is Tourette disorder? Tourette disorder is multiple motor and 1 or more vocal tics occurring longer than 1 year. If your child or you or somebody you know has motor tics, like the eye blinking or the arm moving, and vocal tics like grunting or sniffing or shouting, they have Tourette's disorder. That's all that it is. You have both kinds of tics. We have families coming into our clinic, or when I do talks or workshops, that think that Tourette's disorder, if you have Tourette's, it means you have rage outbursts. It means you pull your hair. It means you wash your hands. It means you're angry. You can't pay attention. Tourette's has become kind of a catch-all term for all sorts of things. And as we'll see, Tourette's disorder is associated with a lot of these other problems. But by definition, Tourette's disorder means only that you have motor and vocal tics occurring longer than 1 year. In tic disorder, NOS, sometimes we see kids with patterns of tics that really don't meet any of the above criteria. It's a neurodevelopmental disorder, so we need to see an onset prior to age 18. If we do have some adults coming in with tics coming in their 20s, 30s, 40s, even 50s or 60s, and those tics, we would not give them a tic disorder diagnosis if we can't establish tics occurring before age 18. They may be related to another kind of a neurologic condition, medication usage, or something else. And unlike most other DSM disorders, impairment is not required for the diagnosis. So just the presence of the tics is enough for the diagnosis. So a little bit more about tics. Tics are neurologic disorders, so we know that they're brain-based disorders. They're not learned. You don't acquire tics, but they are very sensitive to the environment. They're influenced by their surroundings, so there is a behavioral component, and I'm going to talk a lot about behavior therapy today. And this is going to be really important, that you can use behavioral treatments to address a neurologic disorder, and I'm going to explain to you why in a little bit. Tics are more common in males. Some people think 3 to 1, 4 to 1 even. Tics are involuntary. They may be briefly suppressed. You may see kids or adults with tics. If they're in a certain situation, you're in church, you're in the movie, you try to suppress your tics. Sometimes you can for brief periods of time, but it's very difficult to do it on a regular basis. And tics are often preceded by premonitory urges. An urge, a sensation that I'm going to talk about just in a minute, but there's an urge or sensation that precedes the tics, and the child often or the patient will engage in tics to relieve this urge. And tics contribute to social, academic, and occupational problems. There's a whole lot of things that are associated with tics, as you might imagine, making loud noises, screaming, moving, jumping, blinking, frequently throughout the day can lead to issues. As we will see again also in a minute, oftentimes the comorbidities, the ADHD, the anxiety, the OCD that is frequent with tics is more problematic than the actual tics themselves. So let's get back to the premonitory urges, because this is really important when we're thinking about treatment. As I said, there are sensations that precede tics: an unpleasant itch, a tension, a tingle, a kind of a pressure. The urge can be localized. It can be localized. I feel something in my fingers, some energy, and I need to move my fingers to make it go away. I feel something in my throat, like a scratch or an itch in my throat, and I need to clear my throat or cough to try to make that go away. And if you see the little picture there, this is called Touchdown Man. For any of you, it's obvious if you watch football. And this is from Yale, a study that was done at the Yale Child Study Center many years ago. And they asked patients coming in, where were the premonitory urges strongest? And the color shows that these areas. So shoulders you can see and back, and that's associated because people with shrugging tics or moving their tics. You can see the eyes are very dark. That would be blinking. Tics are very common. Legs, the thigh muscles for that would precede tics related to moving the legs, jumping or hopping or leg thrusts. And then hands for tapping, touching, playing with their fingers, for example. So we will always want to assess for premonitory urges. Some tics have specific types of premonitory urges, or at least in terms of location. Now, awareness typically begins around age 9 or 10, although we have worked with kids as young as 4 or 5 years old that can say, I get this feeling before I tic. And it's interesting because younger children may experience the urges and may engage in tics, but may not make the connection that the urges and the tics go together. Over time, this pattern may become more apparent either through learning or because the kids are more aware of how it is. But most, up to about 90% of individuals are going to report a sensation of a tightness or a tingling that occurs before they tic, and they engage in the tic actually to make that feeling go away. Urges are more likely to precede complex tics than simple tics, little eye blinks, a quick arm wave or something. The urge may be very mild or even unnoticeable, but big tics or complex tics, the urge is oftentimes very noticeable. And as I said, when you do the tic, it makes the urge go away. So when we think about tics, this urge-tic relationship is really important. So how do tics feel? So think about when you need to sneeze and you have this sensation and you need to release this sensation, this building pressure, a tickle, whatever it might be. And that's really all you can think about until you sneeze. And once you sneeze, that feeling goes away. Or if your eyes are really dry or your eyes have a little tingle or something in them and you need to blink your eyes, you can't not blink your eyes. It's really, really uncomfortable. And you blink a few times and that feeling goes away. That's exactly what a tic feels like. It's that sensation or feeling that you need to release or resolve, and you engage in the tic and it makes that feeling go away. And when you do that, what that actually does is you relieve this urge. It reinforces the tic. The tics are not great to have, but they make that other bad feeling or sensation go away. And that serves to strengthen and maintain the tics. Again, really important when we're going to start talking about behavior therapy. How common are tic disorders? We know that about 6 per 1,000 kids in the U.S. have our diagnosis of Tourette's, which is actually makes it relatively common. We know 1 to 2 out of every 100 children have Tourette syndrome or another tic disorder. Some of the rates go as high as 2%. And that would be chronic motor or chronic vocal tic. So if you add Tourette's and these other chronic or persistent tic disorders together, that can be 1 even to 2%. And most kids go undiagnosed. An estimated 50% of individuals with tics go undiagnosed because people don't recognize that they're tics. Importantly, however, I said earlier that there's provisional tics where kids at young ages develop tics and then they go away. 10 to 25% of children age 4 to 7 have provisional tics. Really common. And this may be a developmental issue for kids or something inherent in the development of brain and motor control. But we see tics very common in young children. And for most of these kids, the tics are relatively mild. Some are more prominent. But over a period of a few weeks or a few months, they just go away. It's kind of a phase that these kids go through. So the issue is, most of the kids that have this, say 15% on average, yet only 15 out of 100 have these. 150 out of 1,000 kids have tics in childhood. Only about 6 out of 1,000 are going to go on to have Tourette's, and only about 10 to 20 out of 1,000 are going to go on to have a persistent tic disorder. Unfortunately, we don't know. We cannot really predict very well which of these many young children will progress to a persistent tic disorder and which will have their tics resolved. But again, with these younger children, oftentimes we just want to wait and see what happens before we engage in any treatments. So the natural history of tics, there's a very specific development of tics in youth. And this is really pretty invariant. So tics first appear in early childhood. The mean onset, again, is around 5 or 6 years of age for simple motor tics. And facial tics are almost always the first tic, like eye blinking or grimacing or mouth movements, almost always the first tic. They start in the head and the face, and then they progress down the body. Then we may see shoulder shrugging. We may see stomach tensing tics. We may see arm or hand tics, and then leg or foot tics. But they almost always start in the head and face around age 5 or 6, plus or minus a year or two, a couple years even. Vocal tics or phonic tics, same thing, onset usually a couple of years later. Sometimes we see phonic tics or vocal tics like noises in younger kids, but almost always after the onset of the vocal tics. And the type of tics change over time. Tics tend to peak in severity in pre to early adolescence, right around puberty. And then severity oftentimes lessens for kids beginning in mid-adolescence. Not all kids, but a good proportion of kids. And by the time individuals reach late adolescence and even into young adulthood, the tics in about a third of individuals with persistent tics, about a third of cases, the tics will go away completely, and about a third they'll become less severe. And this is in late adolescence, young adulthood. Tics are much less common in adults than in kids as a result of this. Again, we're not very good at predicting which teens or adolescents or children with tics will maintain their tics into adulthood or will have their tics resolved. And we know that tics in females may be slightly less likely to resolve over time. Tics in females, sometimes it can be a little bit more of a severe condition than males. Not always, but on average. So tics are certainly problematic, but for a lot of kids, the tics really don't cause that much difficulty. They're an annoyance, but they're not a big issue. And tics are very comorbid. We see ADHD, OCD, anxiety really commonly in kids. And oftentimes these conditions cause more problems than the tics themselves. So this is a graphic from the Tourette Association of America, which is really the support and advocacy and research group for Tourette's, Tourette.org. And you can see that the tics, when you see somebody with tics, and when we see somebody coming in with tics, you have to assess for ADHD, for OCD, for learning problems, for anxiety, for social issues, for bullying, for all these other things, because this stuff may not be apparent on surface, but in many cases, these kids with tics are going to experiencing one or two or multiple additional issues. And just a breakdown of how common these are. ADHD, which I imagine is of most interest to many of you, and certainly with the attitude community, 50 to 66% of kids with tics have ADHD. It's almost, we just assume ADHD is going to be there unless proven otherwise. And a number of kids that present for treatment of ADHD, a number probably maybe around a third or so may have some tics as well. So I think tics and ADHD, when you see one, you always look for the other. OCD, very common, 20 to 30%. Anxiety, very common, 15 to 20% with a diagnosis, but many more have subclinical anxiety. We see mood issues in about 5 to 20%, depression, for example. The mood issues tend to come on later in adolescence, and typically, and I'm going to show you in a minute what this looks like. Sleep problems, big issue for kids with Tourette's, as with ADHD. And is it solely related to the tics or the ADHD? It's not really clear, but we always look for sleep problems as well. Social problems, again, perhaps due to the comorbid ADHD and anxiety, but even kids with tics only, you can see how tics making these movements, making noises is going to impact social functioning, especially in younger kids where they may not really understand what's going on. And then a subset of children with tics, tic disorders, also experience rage outbursts. And these are very kind of characterized, very intense, abrupt onset tantrums, sometimes triggered for no reason. They may come out of nowhere. They may be triggered by something. The child is really unresponsive. They're so caught up in this rage that they're unresponsive to parents or to pleading or arguing or bribing to get the child to calm down. And then they do resolve after a little bit of time. And typically the kids are very remorseful for what happened, unlike maybe kids with oppositional disorder, or they may not really remember everything that did happen. So we do think that there's a relation here, some kind of underlying neurobiologic relationship between these rage outbursts and tics. Again, it doesn't happen in all kids, a minority of kids, but a significant minority of kids. So the timing of tics and related disorders, ADHD on average is the first onset condition. And this can onset, very young, even, by the age 3, in some cases even earlier. But typically ADHD is becoming apparent, 3, 4, 5 years old. As I said earlier, motor tics typically onset between ages of 5 and 6, although we have seen tics in kids as young as a year old. Vocal tics also, as I said, tend to come on a little bit after a few months or a year or two after the motor tics. And not every child has vocal tics. Actually, there's a big significant chunk of kids that have motor tics only. They wouldn't have Tourette's disorder. They wouldn't have vocal tics. It's motor tics only. But when vocal tics are present, they tend to come on a few months to maybe a year or two after the motor tics, again, on average. And then OCD, the other really common comorbidity, tends to come on a little bit later, usually around age 6, 7, or maybe even 8. All these disorders can be exacerbated, or they tend to be really bad in adolescence. And then with maturation and brain maturation, oftentimes you see some reductions in some of these symptoms, or else better control. You're better able to control some of these symptoms, again, going into adolescence, later adolescence, and young adulthood. So let's talk about the impacts of tics. School can be a big issue. Tics can interfere with reading, test taking, social and sports participation. We have kids with eye blinking tics or head shaking tics. We've seen kids that have to blink their eyes or shake their head every few seconds. Almost impossible to read. Very difficult to pay attention. Makes it hard for sports. In adolescence, older adolescents, it makes it hard to drive. That's a big issue. Kids coming in and saying, I want to be able to drive, and I can't control my head movements. Anxiety and ADHD compound these problems. And some youth with Tourette's may be disciplined for tics or asked to leave the classroom. Because if kids have coprolalia, or they're shouting, or they're making noises, or they're moving a lot, it can be disruptive in the classroom. Not all schools, not all situations, social situations, movie theaters, wherever it might be, buses, are very knowledgeable about or understanding about tics. And kids that are engaging in these behaviors can be disciplined. And some kids with tics may try to camouflage some of these things by taking on more of a class clown persona. We see this in ADHD also, of trying to camouflage the tics by making them purposeful. And again, that can lead to discipline issues as well. And in surveys, we've heard about up to 20% of parents report their child having been asked to leave a school setting due to tics, which can be very devastating in terms of education. I've had patients that I've worked with, and we've seen kids in our clinic that spend more time out of the classroom because of the tics, and it really impacts their learning. Tics tend to be worsened by stress. So if a child has ADHD or a learning disability, or even just tics or anxiety, and they have a big test coming up, that is very likely going to exacerbate their tics. And they may not be able to stay in the class and complete the test, or if they have to give a book report or a group participation, anything that might increase anxiety can serve to worsen tics. And we'll talk about that in a minute as well. ADHD and Tourette's are very common. This is a study by Emily Ricketts, a colleague of mine at UCLA. And they used CDC data, over 5,000 cases, and looked at problems, impairments in youth with Tourette's only, ADH only, and both Tourette's and ADHD. I didn't have the ADHD column on this slide. I couldn't fit it on, but what you can see here that in most cases for academic impairment, the ADHD tends to be contributing more than the Tourette's. And if you look in in this area, the ADHD plus Tourette and the ADHD groups don't differ. Having Tourette's, if you have ADHD, having Tourette's doesn't make a lot of difference, increase impairment to a great extent. If Tourette's only, oftentimes there's not as many academic problems, although you can see problematic handwriting, and that might be because if kids have motor tics and they're always moving, jerking their shoulders, stomping their legs, squeezing their stomachs, making a balling their fist with their hand, that's going to interfere with handwriting. In interpersonal relationships, the tics have pretty significant contribution to impairment, along with the ADHD, although you can see the ADHD still is a bit higher. Interpersonal relationships, feeling treated differently than others, organized activities, again, ADHD tends to carry more of the weight. And then in terms of family problems, financial or occupational problems, because of this, you can see that the Tourette plus ADHD group has more difficulty than the Tourette only group. So Tourette clearly carries its own impairment, but when combined with ADHD, you see more impairment. And when we have this triple combination of Tourette plus ADHD plus OCD, which is actually quite common, these kids are especially have larger problems because of all of these disorders. Anxiety can contribute as well. In terms of race and ethnicity, we've only started doing research in this area relatively recently, which is very unfortunate. But we know, based on the data that we have, that Tourette syndrome affects all races, all ethnicities, all genders, and all ages, across countries. It really seems to be a common underlying condition. Unfortunately, though, white children are twice as likely to have a TS diagnosis than Black or Hispanic youth. And this is related to access to care and education. So that's an area we really need to work on in this. And we know that Black students, males, and students with disabilities are just proportionally disciplined in K through 12 public schools. And again, children with Tourette's would fall into this category, more male. And you can consider Tourette to be a disability of sorts. So these kids are more likely to be disciplined. And again, relevant somewhat to Tourette, but much broader issue is that Black students are suspended over twice the rate of their representation in schools. And we can see that as well. So the big issue that the Tourette community is facing now, it's really pretty difficult, is interactions with law enforcement. So imagine that you're a child or an adult with tics, and I say an adolescent. You have coprolalia, and in coprolalia, people tend to blurt out the words that they least want to say, the most damaging words. Because if you think about this, I have poor impulse control, and I'm around foreigners, and I say, oh no, I don't want to shout out a slur word for the people that I'm with. And the more you think about it, the more it becomes top of mind, and the more anxious you get, and the Tourette is going to latch on that, and you're going to shout that out. At an airport, I don't want to yell out the word bomb. In Tourette's, you're almost invariably, if you have coprolalia, and this is one of your symptoms, it's going to increase the chance you're going to shout something like that out. So we've had a lot of people with Tourette's, older adolescents and adults, have been arrested for this, have been canceled, have been kicked out of schools. Even younger children have been kicked out of schools because people don't recognize this as Tourette's. And that's an issue. I don't know if you can read this card, but the Tourette Association I have tic cards. And the one on the left basically explains why I have a medical condition that makes me have sounds that I can't control. So if I am acting funny, if I'm saying words that are abusive or inappropriate, it's because of this neurologic condition. And these kids are carrying these cards around. The one on the right is a COVID one because a lot of kids have coughing tics and sniffing tics. And of course, they don't want to cough and sniff, but when they're around people and they're afraid to do this, they're thinking about it, they're more likely to cough or sniff, and that can lead to issues. So this is a great resource that the Tourette Association has put out for kids with tics. So let's talk about treatment in the time that we have left. Treatment patterns have changed dramatically over the past 2 decades. Many clinicians still recommend education and passage of time for milder tics. And a lot of this grows out of the fact that, until about 20 years ago, the only treatment for tics were medications. And many clinicians didn't want to give medications to younger kids or kids with milder tics. So it was kind of a watch and wait. And that still is present in many places today. However, behavior therapy has really, over the past 20 years, has really emerged as the consensus recommendation for first-line treatment, even over medication. So the American Academy of Neurology, I was part of this task force, came out with recommendations, treatment recommendations for tics, and the neurologist recommended that do behavior therapy first if you can find it, and then do medication. The European Psychiatry, Canadian Journal of Psychiatry also recommend behavior therapy as the first-line treatment when available. The problem with behavior therapy is that good behavior therapy is not always available. Again, this has only been around for about the last 20 years in a broader availability, but still many communities do not have experience or any behavior therapist. So in that case, medication would certainly be an option. In our clinic, a lot of the kids we work with are on medication and behavior therapy, and that certainly is a combination that we would recommend if needed. But we recommend trying behavior therapy first. If you can get the gains, great, you can stop. If not, you can add the medication. So medical treatment, I'm not going to spend a lot of time talking about this. I'm a psychologist, not a psychiatrist. There's great information both at cdc.org, the Centers for Disease Control have a lot of information on Tourette's, as well as Tourette.org. You can find a lot of information about medication that you can use yourself or bring to your treating physician. Varying levels of evidence and support. Not as much support for a lot of these medications as you might think, but neuroleptic medications like Abilify, strong support for Abilify, risperidone, Pimozide are examples, but these have pretty significant side effects, especially in younger children. Alpha-2 agonists like guanfacine and clonidine also have some benefit. They have milder side effects, but the side effects are still significant. And then there's some newer medications like VMAT inhibitors, topiramate. Botox is actually quite a common treatment now for facial tics. And adolescents and adults, a lot of them, even some in our clinic, are getting this. It's a Botox injection to paralyze the muscles associated with the tics, and it can last from 3 to 4 months, maybe a little bit longer, and it can actually relieve the tics. It can block the tics. Neuromodulation, this is different kinds of brain stimulation and deep brain stimulation, which is a surgical implantation of electrodes for very severe and refractory tics. And these would be more for adults, the latter two. So let's talk about behavior therapy. I want to finish up with behavior therapy. How can a behavioral treatment be effective for a neurologic disorder? Really, what's that all about? Well, ticks are very sensitive to environmental influences. And behavior therapy works by eliminating or reducing these influences. When you put your child on a sticker chart, you are changing the environment. When the child does something you want, they get a reward. When the child does something that you don't want, they don't get a reward. And that's changing the environment. The child is learning that, hey, if I do the right thing, I get something good. So behavior therapy really focuses on influencing the environment in ways to support wanted behaviors and to reduce unwanted behaviors. So environmental influences on ticks, they're neurologic, but those of you that have ticks, have seen people with ticks, have kids with ticks, you know that the ticks are highly variable. Kids can tick more in places or situations. They can tick more around other people. Certain activities can make ticks tick more. And internal experiences, we talked about the premonitory urge, that sensation. Anxiety is a huge trigger. Ticks, when kids are anxious, they tick more. When kids are excited, they may tick more. When kids are tired, they may tick more. Kids may tick more when they're around mom and less with dad. They may tick more when they're at grandma's house and less at school. They may tick more at school, less when they're in other situations. So these are things that we can manipulate to try to reduce the ticks. And we have consequences of ticks. So that's behavior, right? What are the triggers? What's the behavior? And what's the consequence? Certain things can positively reinforce ticks, like reward ticks. So sometimes when kids tick, they get attention. In school, the kids tick and the kids may laugh, or the kids may provide attention in other ways, and that can reinforce the ticks. When kids come home from school and they're ticking, and mom sees them or dad sees them, and you've had a hard day, you're ticking a lot. They can get like a back rub. They can get a special treat. They can do whatever that is. That can also serve to reinforce the ticks. Negative reinforcement means making something bad go away. So when a child ticks and that relieves the premonitory urge, that actually reinforces the tick. When a kid is in a classroom and they don't want to take the test, or they're bored, or they're watching a dumb movie and they're bored, or whatever it is, they're at their dinner table and they tick more, they get to leave and go to their room and play video games. They can go to the library or whatever. That can reinforce the ticks too. When I tick, something good happens. Either I get something good or I lose something bad. And this is called negative reinforcement. I urge, I have the tick, the urge goes away. Hey, that tick is good. Even though the tick is problematic, it makes that urge go away. These are environmental factors that we can address through behavior therapy. We can also, again, the attention, comfort, support. When I tick, I get attention, comfort from mom or someone else. When I tick and I get to stop doing my homework, I can go play, I can leave the classroom. That's negative reinforcement. I'm making something bad go away. So this is how we're going to address ticks. And the behavioral treatment for ticks that's most commonly and most well studied is the comprehensive behavioral intervention for ticks. So this is a treatment that was developed at UCLA along with some other universities. We had done a couple of large studies developing this, 6 universities along with the Tourette Association. And we had NIMH funding to do 2 large trials, one for kids and one for adults, to demonstrate how well it worked. It's a multi-component treatment looking at habit reversal training, which addresses the tick urge function, and function-based intervention, which addresses external factors like leaving the classroom, et cetera. So very quickly, just to go through this, we want to increase awareness of the tick. We want kids to understand and recognize when their premonitory urge is coming. We play catch the tick game. Every time when sitting with the child, every time you feel the urge, raise your finger. And I'm going to raise my finger when I do that too. And you get a reward, you get a sticker, whatever it is. And kids learn how to become aware of the urge. And then what they do is, once you learn how to increase the urge, we teach them something called a competing response, which is a behavior physically incompatible with the tick. So if I have a snorting tick where I'm breathing in through my nose, the competing response might be exhaling through your nose. Breathe in through your mouth and exhale through your nose. You can't do the tick. You can't snort if you're breathing out through your nose. If I have an arm tick like this, it may be holding your arms together. It may be, pushing your shoulders down if you have a shoulder tick. It's an opposite behavior. And kids are taught whenever they feel the urge coming on to engage in this competing response and hold it for a minute or longer until the urge dissipates. And And then the connection between the tick and relief is broken, and the kids learn how to manage the urge, and sometimes the urge will actually disappear. The other thing that we want to look at are function-based interventions. So how do we deal with kids that are getting attention or allowed to escape situations? Again, we want to focus on transitions. Again, with ADHD, same thing. You want to give kids warnings that they need to do homework after school. They get a free time, but then they have to do their homework, reducing anxiety. The most important thing is do not respond to tics in the moment. We want no response to tics, good or bad. And we don't want kids to be allowed to escape from situations. If the tics interfere with homework, they can take a break, but they have to finish their homework. We want to create a tick-neutral environment where the kid doesn't get any positives or negatives as a result of their tics. And these are some of the situations that most commonly worsen tics. TV and video games. This is from a study of ours. 93% of parents said TV video games make my kids' tics go nuts. Home after school, doing homework, in the classroom. These are things that you might expect. And so we want to address these situations and either come up with behavioral strategies or to set limits. So TV or video games, you get 30 minutes, then you take a break, and then you can do another 30 minutes maybe. So, and then kids being told to stop ticking. If I tell you to stop doing something that you can't control, you're going to get self-conscious, you're going to get anxious, you're going to do it more. So that's one of the things that we need to try to work on. This is the most important slide I have. General parenting strategies. This is what we teach all of our parents. Do not react to your child's tics. Don't let anybody else react to your child's tics. If the kid picks up a knife and has a tic like he's going to stab himself, you can react to that. But if they're ticking, you ignore them. We don't want to draw attention to the tics. Express any frustrations with your child's condition only when they're not near you. So, we've had families coming in and if I was a parent, I would do the same thing. They see the kid and they get really upset when the child is ticking, or they're upset, they're afraid, they worry about the future. We don't want the kids to see that. It makes them more sensitive to their tics. Interact with your child about the positive attributes. Don't be the tic police. Focus on the positives. Expect as much from your child as you would if they did not have tics. Tics should never be a reason to lower expectations for anyone. Not all kids with tics may be able to perform at the highest levels, but you shouldn't stop them from trying. We want the kids to maximize their potential. Help your loved ones stay mentally and physically busy. This is the same list for ADHD, sports, whatever it is. Keep them busy, bedtime, sleep, and relaxation strategies for being stressed. How effective is CBIT? It worked quite well. Significantly better than psychoeducation and supportive therapy, which was a comparison. 53% of kids were rated as treatment responders versus only 19% of kids getting social support. This was an 8-week trial. It was very structured. In clinic, we give treatment much longer than 8 weeks. Our outcomes are much higher than this. We didn't compare it to medication, but we looked at a literature review, and CBIT works about as well as medication, as the neuroleptic medications, as the other medications, no side effects, which is really great. We also did a 10-year follow-up the kids in this study, and on average, the kids that responded to CBIT originally maintained their gains 10 years later. So they were at the same level of tic severity 10 years later as when they finished the study, if they had initially responded. That's absolutely remarkable. We also know that telehealth CBIT is as effective as in-person CBIT, and most of the treatment we're doing in our clinic and many clinics is now telehealth. And this shows you here. I have one more slide and then we're going to stop. There's been a rash of what's called functional tic-like behaviors. You may have read about these. Anorexia is another big thing in tics. And these are primarily adolescent girls and young women are coming in with tics. And the tics are really acute, explosive tics. And we see significant worsening of early onset tics or just an onset of new tic disorder. So these are kids that are coming in screaming profanities. They're hitting themselves. They have big arm movements, very dramatic tics. The tics don't follow the typical course. As I said earlier, if we see a kid that comes in and their initial tic was coprolalia, we may not diagnose a tic disorder. Motor tics first, typically around the face, followed by vocal tics a little bit later. And these functional cases are coming in, we can tell, because the child may be 14, 15, 16, even 20, and all of a sudden they develop all of these big tics, arm waving tics, shouting. Those aren't tics in the way that we consider of tic disorder. They don't follow this pattern. There's no premonitory urge. And what we're seeing is a lot of psychosocial stressors, including COVID. We don't see ADHD and OCD, which is really common. We see anxiety and depression as the comorbidities. We don't see a family history of tics or OCD the way we do in kids with Tourette's, but we see neurodevelopmental and emotional disorders. And these kids don't respond to typical tic medications or therapy. But the thing that we do see is all of these kids watch social media, follow Tourette and tic and Tourette related social media. And if you go on social media and look for tic or Tourette, you see all these dramatic presentations of people with these really crazy and big tics. And over the 2 years of pandemic, kids spent all this time watching social media. There are, at last count, over 3 billion hashtag tic or hashtag Tourette's floating around in social media. So these kids are lonely, they're depressed or anxious, isolated because of COVID, less so now, stressed because of the world. And they're watching all of these people with tics and Tourette's having these really insane symptoms. And they're saying, I want to be like that person. These people have millions of followers. They're typically really fun and exciting. And these kids are picking up some of these symptoms through watching them on social media. So it's something to watch out for. We ask all of the kids calling our clinic now, do you follow any social media tic or Tourette? And the treatment then is psychoeducation and working with them to treat the anxiety and the depression. So I went pretty fast. I had a lot in. I wanted to get in, but I think we have some time now for questions.
Thank you so much. That was such important information. Before we start the Q&A, I'd like to thank Inflow once more for sponsoring this webinar. So we got a lot of great questions, as you might imagine, so I'll just get right to it. Someone writes in, if tics can be so disturbing in the classroom, what provision should be made available for children in school?
Well, that's a good question. We typically may want the kids to be sitting somewhere so that all the other kids in the class can't maybe see all the tics. The shouting tic everybody's going to hear, but they can be distracting. So if we can have them sit a little more toward the back of the classroom, can be helpful. A lot of what can also be very important is to work with the school and the classroom and certainly educate the teachers and the school staff, but also the other kids in the classroom and maybe even the kids at school, that these are behaviors that are uncontrollable and the child can't control them, and that they really should just ignore the tics and not treat the child any differently. And we've seen really great response in classrooms where the child may have coprolalia and maybe shouting out profanities, and the other kids are just doing their work and they're really ignoring it. And ignoring these symptoms really can help the children learn to better control themselves, because what happens is the child may shout out a profanity or engage in some tics, feel really self-conscious, feel really anxious about it, feel really bad, like everybody's going to hate me. That just makes the tics worse. So a calmer environment is really important for helping with the tics. In some cases, we might pull the kids out of the classroom for a period of time, but that's very temporary. We want to keep the child in the classroom as much and for as long as possible.
As a school psychologist, when we do an educational evaluation for the school and notice tics in children or adolescents, what are some keywords or important things we should include in our reports for parents to share with doctors? What information can you provide that would be helpful to doctors?
Well, that's a really great question. So we're looking really, for accommodation, it has to be interference with functioning, interference with educational attainment. So kids with tics that are unable to read because, their tics make them, their eyes are moving around or their head's jerking or they're up and out of their seats a lot, can interfere with their ability to read or do homework or to write. Kids can be distracted by the tics. If kids are anxious about their tics, they may not be able to pay attention in class so much. So that's another important accommodation. So really looking at the impact on the classroom, also social functioning, that the kids are really having difficulty because of, sometimes these kids are teased. Sometimes these kids are not included in other types of activities, which can be quite problematic. But I think a lot of this would be the educational attainment. It's impacting their learning, and that's leading to self-esteem. Oftentimes we see anxiety and depression, which would be two other boxes to check again if those are present. Those are present.
Okay. A mom writes that her child with ADHD is 13, and he frequently yells, "Shut up, stop, die," with no provocation, but he seems angry and it seems to be directed at family members. Mm-hmm. Could this be Tourette disorder or tic disorder?
It could be. And that's one of the things that we always get, when the kids come in and they're, especially, the sisters oftentimes take a big brunt, but the parents as well. What we would look for, the history of tics. Again, this very kind of specific. Did the child have motor tics? Other kinds of muscle tics earlier on in when they were younger. Did they have other vocal tics as well? What are the triggers for these? Does a child only do it when he's angry? Does it seem like it is not in the child's control? Does the child feel bad or remorseful after? What other things are going on? So we have kids that come in and they have coprolalia, and then we'll talk to them or the parent, and they also yell at the mom. They say, "No, I yell at my sister when I'm mad at her. That's not a tic. When I shout out this other word, that's a tic." So the kids may be able to know if they have other tics, and they can make the discrimination. So I would consider it. I would think about an evaluation for tics. Early tics may be in there somewhere, and they may have been missed, or you didn't make the connection.
Okay. A parent says that her child's tics seem to be much worse when he's trying to sleep. Why would this be? It seems to be a time of low stress for my child, she says.
It's so interesting. I think tics are one of the few neurologic disorders that actually can occur in sleep. And it may be that, in fact, when the child is sleeping, she may be, she may not, obviously she's not aware of the tics, so she may not be trying to suppress the tics. When kids, most of the time during the day, kids are engaged in some suppression of the tics if they can, but they get tired, they aren't able to do it. When a child is sleeping or maybe even starting to fall asleep, she's relaxed, and it may just be that she's kind of letting go and letting the tics fly. And certainly when she's asleep, it may be that way as well. We do see tics in sleep, and it can interfere with sleep.
Speaking of tic suppression, someone writes, "My child has meltdowns almost daily because he masks at school. What can we do to help our children after school?"
Because he what at school?
He has meltdowns because he masks at school, or in other words, he tries to suppress his tics. What can we do to help our children after school?
That can be so hard. It takes so much energy. And when kids come home, is oftentimes we see a big burst of tics because the kids have been trying to suppress the tics or mask the tics. Treatment, is important if you can find behavior therapy or other treatments to help the child learn how to manage tics, reducing anxiety, giving the child a break. I think I said earlier, we recommend when the kids come home from school and they're really tired and anxious, and they may really rage or whatever, the first thing is to try to do some kind of a calming activity with them. That maybe they can help them settle down or calm down, get a snack, get something to drink. On the Care Center website, which is another thing we have at UCLA, carecenter.ucla.edu, we have pages of strategies for just kind of relaxation, little exercises, breathing exercises, some other kinds of exercises for managing stress. You can find these online as well. And maybe when the child gets home, the first thing is to engage in some of these activities with them. But really trying to help the child if there's opportunities for getting treatment or trying to reduce the stress of tics at school. If the classroom is educated and the teacher, and maybe if he doesn't need to suppress at school so much, that's going to save some energy. So when he gets home, he won't be so tired or dysregulated.
Someone wants to know if tic disorders go away in childhood, can they suddenly recur in adulthood?
That's a really interesting question. I don't know the answer to that. I'm not sure we've seen that. We have seen cases where the tics, and a lot of times when the tics go away, it doesn't mean they disappear, but it means they become milder, or the individual, the child or adolescent, or even adult, has just learned to manage the urges. You learn better self-control. And I may feel like I want to tic. It's the same thing. I used to smoke. I feel like I want a cigarette, but I feel the urge, but I don't give into it. It may be something like that, but during a time of stress or illness or change or whatever, an adult, the individual's abilities to manage the urges may lessen and the tics may reemerge. That's the only thing I could possibly think of.
Mm-hmm. Can a family physician diagnose these disorders, or should it be a psychiatrist?
Family physician can diagnose them. Psychologists can diagnose these as well. When we see kids with tics, and we're pretty careful. We don't need the pediatrician or anything involved. If there are other kinds of issues that are going on, or some of the tics may make us think of a different kind of a neurologic disorder, we might say you should go to your pediatrician and get an evaluation. But they're not really that difficult to diagnose in most cases. So psychologist, psychiatrist, pediatrician.
Okay, well, unfortunately, we're out of time. But we thank you, Dr. Piacentini, for joining us today and for sharing your expertise with our ADHD community. And make sure you don't miss future Attitude webinars, articles, or research updates by signing up to receive our free email newsletters at attitudemag.com/newsletters. If you're listening in replay or podcast mode, visit attitudemag.com and search podcast 422 to access the slides, the webinar replay, and the certificate of attendance option. If you support the work we're doing here at Attitude to strengthen the ADHD community, we encourage you to visit attitudemag.com/subscribe and sign up for Attitude Magazine. You won't want to miss our special Success at School issue in the latest fall issue. Learn how to set smarter IEP goals, how to help your child build resilience, how to win over a new teacher, and so much more. Subscribe today for your family or to share with a teacher or a loved one who could benefit from greater ADHD understanding. Thank you.
For more Attitude podcasts and information on living well with attention deficit, visit attitudemag.com. That's ADDITUDEMAG.com.